Good afternoon, and welcome to our Multi-Modality Imaging Conference. I'm Miguel Quinones, and today we're going to discuss the diseases of the aorta. And the imaging of the aorta currently has become exquisitely well done by CT and MRI. Ultrasound still plays a role, but it's more limited. So we're going to start our conference first with a discussion of the role of CT and MRI. And for that purpose, we couldn't have anyone better than Dr. Chamsi-Pasha to discuss it. However, Dr. Chamsi-Pasha was not physically here today, so he was kind enough to pre-record the presentation, which we will be immediately starting. And then after that, I will discuss the role of ultrasound.
Good afternoon, everyone, and thank you for joining us. Sorry I could not be with you in person, but the topic would be the use of advanced cardiac imaging for evaluating and managing aortic disease. As Dr. Quinones have alluded to, that we really have with echocardiography, whether with transthoracic or transesophageal echo, a good visualization on a two-dimensional aspect for the aortic root, along with the proximal ascending thoracic aorta, typically anywhere between 100 to 120 degrees. Now, notice that this actually can't suffice for people who have proximal aneurysm of their ascending aorta, because I can actually see the aortic root over here, and I can also measure the first 3 centimeter of the ascending aorta. In this case over here, it's almost like an 8 centimeter. That's actually easily identifiable. So where transthoracic echocardiography would be helpful is for serial measurements of the aortic root diameter. Remember that sometimes you can have asymmetry of those sinuses, so keep that in mind. If there's any aortic valve pathology, for example, aortic regurgitation, that can happen because of a dilated aortic root, and the suprasternal views are usually helpful to show dissections, coarctations, or PDA. And a transesophageal echocardiography would be helpful to show the segment of the proximal ascending along with the distal ascending aorta, typically when we see the aorta just before the innominate artery becomes before we hit that blind spot when we are retrieving our probe from the distal descending aorta all the way to the ascending aorta. And this is usually what I tell the fellows on the transesophageal echo is typically this is going to be your dissection plane on TE. When you pull the probe back and you dial down on the Omni down to 100 degrees, you can actually beautifully visualize the ascending thoracic aorta. Now, most of my talk is going to be based off on the 2022 ACC/AHA guidelines that was published. And the role for advanced cardiac imaging, particularly CT and MR, is that it provides a wide coverage field of view where you can evaluate the entire thoracic aorta with excellent image quality. You typically have isotropic voxels with CT/CMR, but you can also basically acquire a 3D volume data set by which it allows you to reconstruct the aorta in any plane. This is a rotating 3D magnetic resonance angiography of the aorta along with its brachiocephalic, subclavian, and abdominal aorta branches. And this is a reconstruction from a CT curved planar reformat showing you the aortic valve all the way down to the distal abdominal aorta. And you could even actually appreciate very minimal amount of plaques and calcium that could be present in those segments. So where does advanced cardiac imaging play a role when it comes to CT and MR? Obviously, at our institution, both are available. Unfortunately, patients have to go to the scanner, so there is no portability on both. The speed of acquisition is definitely a plus with CT compared to CMR. I think both have enough spatial resolution to make a diagnosis, but we all know that the CT has an outperforming spatial resolution down to the 0.5 millimeter. And now with the new generation scanner, we can get images down to 0.2 millimeter pixel size. And then 3-dimensional data set can be obtained with both. But obviously, if I need any dynamic imaging, whether for the valve or whether for the ventricular function, then obviously you need to use MRI if the echocardiographic examination is not adequate. A lot of advantages for CT, as we said, universally available, but we need that electrocardiogram gating. It has a relatively short scan time, a higher spatial resolution, coronary evaluation, but really kind of where the crux of the MRI is two things. Number one, you can get more of the tissue characterization if you're suspecting vasculitis or you are suspecting any disease that's involving the aortic wall, for example, intramural hematoma. Dynamic imaging, particularly with dissection, because CT, although you can do dynamic imaging with CT, you're going to expose the patient to more radiation. Aortic valve pathology can be easily identified because you can acquire cine images with CMR. And then remember that it's radiation-free for the young female pregnant patients and those who need serial imaging. Now, this is basically what a timed resolved angiography with MR looks like. So this is a 3D data set where we're acquiring actually every few seconds an image. And then basically we're seeing in real time the contrast bolus going in from the SVC to the pulmonary artery and then going back and filling out the whole thoracic and descending aorta. And you can see actually there is a penetrating ulcer right over here. And the new guidelines talk about standardizing those aortic anatomical segments by looking at the landing zone. So that's typically what surgeons use in order for planning for example, TVAR. So the zone 0 is going to be from the ascending to the origin of the innominate artery. Zone 1 is going to be the origin of the left common carotid. Zone 2 is going to be the origin of the left subclavian. Zone 3 is the first 2 centimeter distal to the left subclavian. Zone 4 is going to be from the end of zone 3 to the mid-descending aorta. And then zone 5 is going to be from the remainder of the descending aorta all the way down to the iliac. It is very critical when I want to measure the diameter of the aorta is basically I need to create what we call a double orthogonal view. So this is a sagittal plane. This is a coronal plane. If I take a look at my orange reference line, and this orange line is perpendicular to the wall of the aorta on this coronal view and perpendicular to the wall of the aorta on this sagittal view, you're going to end up with a true short axis image of the heart in a plane that's perpendicular to the axis of blood flow. Here, you're getting a dimension of 4.8 centimeter. One important thing about using CT and CMR for measuring aorta is typical in echocardiography. We use the leading edge to leading edge and we measure in diastole. We still want to measure in diastole for our CT and CMR, but we want to use the inner edge to inner edge or the inner wall to inner wall. And these are the standard landmarks that we should report on our CTA or MRA. The root, STJ, mid, distal, arch, proximal, and mid-descending aorta. So the take-home message is that we typically use the inner edge to inner edge on cross-sectional imaging like CT or CMR, unlike echocardiography. Now, when we talk about thoracic aneurysms, this is actually a 3D volume rendered image with CT that's actually showing you this proximal ascending aortic aneurysm that's involving the root. It's by definition a localized dilation, reaching 1.5 times the expected diameter of the vessel. Now, the standard definition does not apply to the root and the ascending aorta. Now, the 2022 guidelines recommend using an absolute cutoff of 4.5 centimeter for these segments. Aortic disease is increasing in incidence. And this is actually something that because of our aging population, along with greater imaging that patients are coming across. One key factor in the guidelines is basically patients with thoracic aortic disease. When should we consider a genetic testing? There's probably a 10 to 15% of patients with thoracic aortic disease can have an underlying hereditary gene mutation. Who are these people? If they have any features of Marfan syndrome, Lewis-Dietz syndrome, or the vascular type of Ehlers-Danlos syndrome, if there's any family history of thoracic aortic disease, if they develop the thoracic aortic disease at a young age, whether that is an aneurysm or a dissection, these are the people who would benefit from a genetic testing. If they have a positive result suggesting a pathogenic or a likely pathogenic variant, then you would do cascade testing for those at-risk relatives. The guidelines also mentioned when should we use an indexed values. So when the height or the body size is actually outside the 1 to 2 standard deviation of the mean, they do actually recommend using what we call the aortic size index. By definition is the aortic diameter in centimeter divided by the body surface area, or to index to height, so an aortic height index, and also consider using a cross-sectional area to height. So if I measure the area of the ascending aorta and I divide it by the patient's height, the magic number is more than 10 square centimeter per meter. This has been shown to be an independent predictor for worse outcomes. This is a study many years ago from the Cleveland Clinic that actually looked at the area of the ascending aorta. You can actually see it over here, divided by the patient height. And if that's more than 10 square centimeter, then this was independently associated with cardiovascular death and a much superior predictor to aortic dissection. When do we intervene on patients with either aneurysms of the aortic root or ascending aorta? We said that the cutoff is now 4.5 centimeter to call aneurysm for the root and the ascending aorta. So typically, if someone is not symptomatic, then you want to look at that maximal diameter. There's a class 1 recommendation to basically do an elective thoracic aneurysm repair if the aorta is more than 5.5 centimeter. How about if it's not at 5.5 centimeter, but it's less? If there has been a rapid growth by more than 3 millimeter per year over 2 years, or more than 5 millimeter in 1 year, that's a class 1 recommendation. And now in the guidelines, if the maximal diameter is more than 5 centimeter, then surgery is reasonable by an experienced surgeon if it's done in a multidisciplinary aorta team. And now that's a class 2A. They also basically included the patient's maximal cross-sectional aortic area to height ratio. If that's more than 10, then this also will give you a class 2A for intervening on patients with an ascending aortic aneurysm of 5 centimeter. If the patient is undergoing a repair or replacement of their tricuspid aortic valve and they have a concomitant aneurysm of more than 4.5 centimeter, then it's a class 2A to replace the ascending aorta. This is a sagittal view of a patient who has a heavily calcified aortic valve. We can see on this short axis view that this is a bicuspid aortic valve. This is going to be here Sievers class 0. So technically the left coronary cusps and the right coronary cusps appears to be, there's only basically one opening across those cusps, and there's no raphe to kind of tell where is the fusion. But you could see actually that there is a stenotic valve on this CT. And remember that patients with bicuspid aortic valve, it's not only a valvular problem, but they also have an aorta pathology. So hence they are prone for aneurysm. 20% of patients with bicuspid aortic valve who develop aneurysm will require a repair, and 15% of patients with aortic dissection have an underlying bicuspid aortic valve. This is kind of the recent updated nomenclature by the European guidelines to kind of replace the old Sievers classification, where they talk about the 3 phenotypes of the fused bicuspid aortic valve. So they talk about the right to left cusp fusion, which is the most common, the right to non-cusp fusion, which is the second most common, and then the left non-cusp fusion. There is also the 2 sinus bicuspid aortic valve. So this is, think about this as your Sievers type 0, where the valve can actually open either lateral to lateral or anterior-posterior. And then there's the form frustae, a bicuspid aortic valve, where you have a partial fusion. The aortic phenotype of bicuspid valve, the most common one is the tubular ascending aorta being involved. Less common is the root phenotype with preservation of the ascending aorta, and then not infrequently seen is when you have an extended phenotype involving the root and the ascending aorta. This is a transesophageal echocardiogram of a patient who basically has a large dissecting aneurysm, and you can see it actually over here, the dissection plane, in this descending thoracic aorta. Cardiac CT, in this case here, is the short axis where we actually measure the internal dimension perpendicular to the blood flow. And you can see actually over here the effacement of the ST junction on this cardiac CT scan. Now, when is the indication to replace whether the aortic root or the ascending aorta? Typically, it's the same cutoff of 5.5 centimeter. It's a class of recommendation 1, level of evidence B. And now, basically, in this guidelines, in patients with bicuspid aortic valve and a cross-sectional area to height ratio more than 10 is a class 2A based on the literature published from the Cleveland Clinic. Now, this is a magnetic resonance angiography. So this is a 3D acquisition, ascending aorta, descending aorta. And what we are seeing over here, there's an aneurysmal dilation of the descending thoracic aorta. If you actually go back over here, the size of this descending aorta is large. And number two, there's actually a lot of diffuse atherothrombotic lesions. So these are basically all these protruding plaques. And the way basically we diagnose a descending thoracic aorta aneurysm is if it hits a 4.0 centimeter or above. When are we supposed, or what is the threshold to repair? It's the same threshold as we use for the ascending aorta. Typically, it's 5.5 centimeter, assuming that the patient is at average operative risk and average risk of rupture. But if the patient is at an elevated risk because of advanced age, CKD, advanced COPD, or prior stroke, then you really have to weigh the risks and benefits of intervening versus a watchful waiting strategy. So take-home message number two, when the aortic root or the ascending aorta is more than 4.5 centimeter, by definition, this segment is aneurysmal, whether the patient has a bicuspid or a trileaflet valve. And then you want to use the index values when the patient's height or body surface area is outside the 1 to 2 standard deviation. Let me see whether this one plays. So this is a patient of mine who's 46. He has actually a trileaflet aortic valve, as you can see over here, but his ascending aortic root is actually aneurysmal, and we were measuring almost a 5.1 centimeter of the aortic root. He was tall, he was thin, and he had this unidentified connective tissue disease because of all of his genetic testing was actually unremarkable. So when we measure actually over here, we measured actually a 5.3 centimeter of his aortic root. And this is going to be here, the left cusp. This one here is going to be the right cusp. This one here is going to be the non-cusp. And the root phenotype, as we know, has basically been recognized to have a more malignant behavior of the dilation compared to the tubular ascending aorta. And this patient actually, because it's a class 2A for an elective repair, he did actually do well after having his root replacement with a Dacron graft. Now compare and contrast this to some of our Marfan's patients. So take a look at this left coronary cusp, which is aneurysmal. It's almost more than 6 centimeter, the maximal dimension of the aortic root from the left to the opposite coronary sinus. Not only that, but this young patient actually came in with chest pain because there is a significant luminal compression of the left main, and the reason behind that because of the overstretch of the left sinus of Valsalva, creating a compression of the left main coronary artery, for which this patient actually had to undergo a second surgery to replace that aortic root. Prior to that, the patient did have a DeBakey type 1 dissection. As you can see here, the ascending aorta has already been grafted in this patient with a residual dissection plane at the base of that left coronary cusp. Now, is there any role for medical management? There has been basically multiple randomized trials in Marfan syndrome, treating those patients with either a beta blocker or an angiotensin receptor blocker in a maximally tolerated dose is recommended to reduce the rate of aortic dilation. That's a class 1 level of evidence A. And then the adjunct use of both a beta blocker and an angiotensin receptor blocker is a class 2A recommendation based on the updated European Society guidelines. So this is just kind of actually to summarize for sporadic and bicuspid aortic valve aneurysm, 5.5 is a class 1, 5 centimeter is a class 2A. For Marfan syndrome, a class of recommendation is 5 centimeter and more than 4.5 centimeter in those with increased risk of aortic dissection. Different spectrum of thoracic aneurysms can actually be seen. This is the classic tubular ascending aorta aneurysm. This is a patient who has Turner syndrome. So you can see the severe pectus excavatum. And these people actually, their thoracic aorta is actually smaller because of their short stature. This is a patient who has a saccular aneurysm of the thoracic ascending aorta. This one was believed to be more mycotic in relationship. And this is a patient who has a diffuse aortic wall thickening consistent with Takayasu arthritis seen on CT. Now, moving gears to basically an abdominal aorta, we typically see the abdominal aorta in our subcostal images. So believe it or not, this is actually the dimension of the abdominal aorta from here all the way up to here. And you have this large mural thrombus present in this abdominal aorta. This is what it looks like on a 3-dimensional CT scan. So you have the most common location is the infrarenal abdominal aortic aneurysm, as you can see in this case. And typically the guideline for repairing those abdominal aortic aneurysms, assuming that they are unruptured, is we use basically the cutoff of 5.5 centimeter in men or 5 centimeter in women. So that's a class 1A. And then basically, if there is a growth in the aneurysm of more than 5 millimeter in 6 months, then a repair to reduce the risk of rupture may be reasonable, and that's a class 2B in patients with abdominal aortic aneurysm. Now, moving on to a different aortic disease pathology, in this case is the aortic coarctation. So by definition, it's this focal narrowing of the thoracic aorta, and most commonly it's at the juxtaductal segment, right at the isthmus, and it's usually caused by a fibrous ridge and an abnormal hyperplasia of the tunica media. Notice how actually the left subclavian artery is usually the hallmark for distinguishing the juxtaductal from the preductal, which is a less common type. But notice how basically there is engorgement of the blood vessels, in this case, both internal mammary arteries, because of the pressure difference proximal versus distal to the juxtaductal aorta. This is what it looks like on a cine CMR. This is a bright blood imaging technique without the need for contrast. This is the ascending aorta. This is the arch. This is the isthmus. And this is how the post-stenotic dilation of the proximal descending aorta. That's how we identify coarctation. Once we add contrast, gadolinium in this case, to create an MR angiography, you can actually see the fibrous ridge, you can see the severe coarctation, and you can see basically all the collateral blood vessels seen at this coarcted segments. Now let's move on to acute aortic syndrome, which usually spans through 3 different pathologies. Aortic dissection is probably the one that we are more familiar with because it's a true emergency where you have an entrance tear in the intimal layer, and that basically creates blood to go through the true lumen and then blood going through the false lumen with a intimal flap. We also have an intramural hematoma, as the name implies. It's a rupture of the vasa vasorum. So that's basically inside the tunica media. And basically hematoma can form and then create a compression of the true lumen. And then a penetrating aortic ulcer, as the name implies, you have a plaque that actually is ulcerating. And that basically, if it happens at the ascending aorta, can have a risk of progression to aortic dissection. Now, we all know about the DeBakey type 1, which involves both the proximal and involves the ascending and the descending thoracic aorta. And then the DeBakey type 2, which is only localized to the ascending thoracic aorta, or basically that's going to be your zone 0. And this is basically all Stanford A, which requires surgical emergency, versus Stanford B. One is basically supra-inguinal, and the other one is basically infra-inguinal, and these are basically the DeBakey type 3A and DeBakey type 3B. We see here the frequency of the acute aortic syndrome. The most common one is the DeBakey type 1, and then basically the less common one is the DeBakey type 2. Now, we all know Dr. Michael DeBakey has had an aortic dissection, and in his 90s, they were debating whether or not he would benefit from surgery, but he was the oldest patient to benefit from an aortic dissection surgery, and he lived for almost a year and a half after his aortic dissection. Now, the lifetime natural history do actually come at various sizes of the aorta. So from the 1997, we actually realized that if we follow those ascending aortas, right at the 6 centimeter cutoff, you have an inflection point where there's a significant increased risk of aortic complications if you leave those aortas at 6 centimeter. And you could actually see that in the descending aorta, it's actually even larger, like almost 7 centimeter. Now, these were kind of old historic studies, but now actually more contemporary studies have suggested that type A dissections can even occur, and they mostly occur in aorta that are small in sizes. So take a look over here. The relative risk of an aortic dissection between 4 to 4.4 is almost basically 89 when you look at the relative risk compared to those with a aortic size less than 3.4. And then you have a significant increase in the risk of dissection once the aorta basically goes 4.5 centimeter and above. So, but you can still actually see even that the aorta that's less than 4.5 centimeter, there are basically some cases where dissections can happen. Now we have better imaging methods, larger series, and more accurate analysis. If we take a look basically at these 2 papers, this first one over here, and the y-axis is the average yearly rate, and you could see actually here the rupture, dissection, and death. And the risk basically between 5 to 5.5 centimeter is around 5.8%. But the risk is not 0 if your aorta is less than 5 centimeter. It's between 4.5 and 5 centimeter, you have a 4%. and then 4 to 4.4 centimeters, 4.3%. But definitely once it is above 6 centimeter, the risk basically becomes significantly exponential. And if we take a look basically at aortic dissections over here, along with the models using the most recent thoracic aorta sizes in this large sample size, we can see that the aortic dissection in the 4.5 centimeter and above, you have a twofold increase. Didn't reach statistical significance, but it's 5 centimeter and above, you almost have a 5-fold increase that is significantly associated with increased risk of aortic dissection. Now, dissections come in different flavors. So this is actually a DeBakey type 2 dissection, but it's interesting enough that's only localized to the proximal ascending aorta. And this was actually a patient who had a traumatic chest wall injury. So you could see actually here where the false lumen separating from the true lumen, it's actually creating this localized dissecting aneurysm. What are we supposed to report in imaging an aortic dissection? We really need to kind of tell them the extent of the dissection, both proximal and distal. If we identify the entry or exit tear, where is the site? We need to provide accurate dimensions of the aorta to involve both the true lumen and the false lumen. And then we also want to look at those branch vessels, particularly the neck vessels from the arch or the branch vessels from the abdominal aorta, to see whether they're rising from the true lumen or the false lumen. This is where MRI plays a role, and our surgeons love it because it provides them with dynamic imaging. The life-threatening complications of dissection, if there is a pericardial hematoma or mediastinal hemorrhage, an acute aortic valve regurgitation, coronary artery or carotid artery dissection, and malperfusion syndromes. CT versus CMR both provide excellent gold standard, very high sensitivity and specificity approaching 99 to 100%. Remember also that D-dimer actually can be used with, I would say, modest sensitivity and modest specificity for patients with acute aortic syndrome. So for patients presenting with a type A aortic dissection, obviously you have to look at the root. You basically need to see whether or not the patient has a known genetic disorder, because this means that you have to replace the valve and the root using a valved conduit. If the patient is older, you probably want to use a biological, but if the patient is younger, you want to use a mechanical. But in patients basically who have no intimal tear in the arch or a significant arch aneurysm, which majority of the patients present with, then a hemi-arch repair is going to be recommended over a more extensive arch replacement. But if the dissection flap basically is extending through the arch and into the descending aorta, then this is where you want to use an elephant trunk with an extended arch repair, and to consider basically having a stent from the proximal descending aorta in order to reduce the risk for late distal aortic complication. Remember, echo is first. The sensitivity for type A dissection on a transthoracic echocardiogram showing this proximal ascending aorta is almost 87 to 92%. And you can see this dynamic dissection flap in this patient presenting with chest pain. I can also see this dynamic dissection flap in this patient with a DeBakey type 1 aortic dissection. So you could see actually the entry tear is wide and large. The dissection flap is extending all the way to the brachiocephalic trunk, and you actually have this double barrel lumen. This is going to be the true lumen. This is going to be the false lumen. Notice how the true lumen expands in systole, and because the false lumen is patent, it's actually creating a pressure effect and a collapse over the true lumen. If there is basically less flow in the false lumen, as we can see over here, then typically you're going to end up with an intraluminal thrombus. The role of CMR in aortic dissection, typically we start with non-contrast images, and we acquire those series, axial series of bright blood imaging. So we actually use the bright blood image, and we also use the dark blood images. And this is what you're showing you over here. This is going to be the true lumen in the center. All of this is going to be the false lumen. You can actually see the extent of this aortic dissection, almost like a 360-degree of this patient. And then I can also actually appreciate over here the celiac artery coming from the true lumen. The spiral dissection continues in the abdominal aorta, as we see over here. And you could actually then, these are the non-contrast images, and then we're going to forward those with dynamic imaging. So you could see actually this patient with complicated aortic dissection. I see the dissection plane here. I also see the dissection plane over here. This is going to be the true lumen, which is expanding in systole, and the false lumen is patent. and you need to actually assess the dynamicity of that intimal flap in order to rule out any dynamic compression, similar to how actually this true lumen in the abdominal aorta, right at the origin of the celiac, is completely collapsible by the high pressure in the false lumen. So this patient would be at risk for malperfusion syndrome. We already know what the medical management of acute aortic syndrome. You really need to kind of decrease that DP, DT, which is the rate pressure control. And hence, we always use our beta blockers, labetalol or esmolol, first to get a heart rate less than 60. You want to optimize pain control. And then if the blood pressure is more than 120, you really want to administer second-line vasodilators. These could be direct vasodilators like nitroprusside, or can be IV calcium channel blockers like nicardipine. And the goal is to get the blood pressure less than 120 in order to maintain adequate organ perfusion. What is a complicated type B aortic dissection? Remember, this is going to be your DeBakey type 3. And this is basically going to be what we call complicated aortic dissection. If there's a contained rupture, if there is any signs or symptoms of organ malperfusion like increased creatinine, increased lactic acid, the extension of the dissection, the progressive aortic enlargement, and if there's any refractory hypertension. For those patients, you really want to consider the thoracic endovascular aneurysmal repair, which is TEVAR, which is now considered to be more favorable for management compared to open repair. For our CT chest pain protocol, we always acquire a non-contrast CT. And the reason behind that, because you can see actually this crescent shape, very high attenuating thick wall in the aorta. And what happens is that this is actually the area of blood that's entrapped, or the hematoma that's entrapped in the tunica media. And this actually can create a nidus for progression to aortic dissection. And it's always evident before you administer intra-arterial contrast, which is going to decrease the signal to noise ratio, and you're not going to be able to appreciate. This is an intramural hematoma in the mid-ascending aorta, extending all the way up to the distal ascending aorta and the aortic arch. How does it look like on transesophageal echocardiography? You can see over here, this is the aorta, and you could see actually between the tunica intima and the tunica adventitia, you actually have a hematoma that's actually entrapped within the aortic wall. And sometimes actually you can see calcium get displaced outside, particularly when the calcium is actually sitting at the aortic wall. We don't see it over here, but this patient has both a significant protruding atherosclerotic plaque and an intramural hematoma using transesophageal echocardiography with biplane imaging. Now, this patient got transferred to us post-heart catheterization, and the reason behind that, because now you see actually there is a catheter in the left main, and you can see actually there is dye hanging over here in the aortic root, and it's actually extending to the proximal ascending aorta. So this is basically, by the Cleveland Clinic classification, is what's called the type 5 iatrogenic aortic dissection. So there's a catheter went in, and then the catheter induced a dissection of the wall. Sometimes the dissection involves the coronary arteries, and sometimes it doesn't. And then the dissection typically sits on the greater wall of the ascending aorta. So this is actually what it looks like on a CT. You could see actually over here, there is this crescent shape, hypodensity within the ascending aorta. But notice that when I give contrast, the area is not enhancing. So that's basically number one. So unlike classic dissections where you're going to see contrast going into that area. And then number two, there is no intimal tear. So if I take a look at this is a patient that they had to leave their coronary wire in because they were actually planning to do a staged PCI. But notice actually over here how there is no intimal tear. And more importantly, it's actually kind of stick to the same greater curvature of the aortic wall, and there is no spiraling, unlike dissection where you actually can have a spiraling effect plus contrast enhancement and a tear. Now, if someone has a complicated intramural hematoma, so they're basically presenting acutely, and it's actually involving the ascending aorta, then by definition, they have to undergo an urgent repair. But if this is actually uncomplicated and it's a type A, meaning that it's involving the ascending aorta, then actually still the guidelines recommend open repair. But for those patients who are at increased operative risk, they can actually be medically observed, and that's something that can be considered. For that case, with the iatrogenic aortic dissection post-left heart cath, the patient did well after serial imaging, and there was no progression of their hematoma. If this was a type B, so involving the descending thoracic aorta, then medical therapy would be actually recommended. But if there are basically any high-risk features, then basically we can consider doing an intervention. So what are some of the high-risk features? If the aorta is basically more than 45 in the type A or more than 47 in the type B, if the hematoma thickness is getting thicker, more than 10 or 13 millimeter, and then if there's any focal intimal disruption with ulcer-like projections, and if there is any pericardial effusion. These are some of the things that we would need to report on whenever we see those intramural hematoma. These are basically CT images showing these multiple ulcerations. And this one over here, you can see kind of a mushroom out-pouching of this plaque that's actually protruding into the tunica media. So this is what a penetrating aortic ulcer would look like. We also basically not infrequently on echocardiography, especially TE, we can see those large protruding atherosclerotic plaques. There is really no intramural hematoma because everything seems to be kind of covering the tunica intima, which is actually over here. And all this burden or plaque is actually kind of protruding into the vessel wall. And then this is actually what it looks like on a 3D TE. You could see actually these plaques actually building up in the descending aorta. And one of them actually has a small mobile component. And then this is what it looks like on a CT. So this is a sagittal view. This is going to be the STJ, ascending aorta. This is going to be the distal, or I'm sorry, the ascending, or the aortic arch. This is the aortic isthmus. And you can see actually those large irregular shape plaques. A lot of the times those CATs classified atherosclerotic plaque type 4 and above based on thickness of more than 4 millimeter, they actually do harbor in them thrombus. So a lot of the times on histopathology, you'll see atherothrombotic lesions, and these basically could be anitis for stroke or peripheral embolization. A lot of the times, those aortic atherosclerotic disease, unfortunately, they are associated with CAD, PAD, and increased risk of all-cause mortality. By definition, it's recommended to prescribe an antiplatelet. Anticoagulant is basically something that may be considered, but unfortunately, there is no strong recommendation. And it's actually reasonable to prescribe a moderate or high-intensity statin for those patients in order to decrease the atherosclerotic debris. This is a case actually which actually is one of those complicated or acute aortic syndromes where you have actually plaque, and then you actually have a penetration of the plaque that's actually almost like creating an exophytic lesion. So this is what it looks like on a 3D MRA, where actually this now blood is actually trapped through this space or through this cavity because of the protrusion of the atherosclerotic plaque. So it's actually seen right over here. And there are basically 46% of those penetrating aortic ulcers progress to dissection or intramural hematoma after 12 months. So they have to be serially monitored. Not going to belabor you, but technically we're supposed to provide the maximal aorta dimension, including the ulcer side. We're also expected to kind of get the width. We're also expected to get the length of the intimal defect, along with the depth of the intra blood pool. This is basically a patient with a very mobile atherosclerotic plaque. The beauty about transesophageal echocardiography, because it provides you with this real-time imaging. And I'm going to show you this case of Lerich syndrome, which by definition is an aortoiliac occlusion. This is actually using CT. You could see actually over here, the distal abdominal aorta is completely occluded, and then there is collateral circulation that's going down to the legs. Think about this in those patients who present with impotence and also present with intermittent claudication. So to kind of summarize, these are the essential elements when I'm doing my CT and MRI imaging. I need the maximal aortic diameter because it's going to help me risk stratify who's going to benefit from a repair or surgery or not. If there are any abnormalities of the aortic wall, the presence of plaque, thickening, or thrombus, describe the areas of the luminal stenosis or occlusion if present. And if there is an acute aortic syndrome, I need to tell whether this is proximal, distal extension, entry tear, and complications, branch vessel involvement, malperfusion, and organ injury, the disease classification, and then more importantly is that both on CT and MRI, we acquire images with electrocardiogram gating, and we also try to optimize those images to be done during diastole, similar to how we do our echo imaging. These are some of the key reference papers along with the guidelines. With that, I would like to conclude, and I thank you all for your attention.
Thank you very much, Dr. Chamsi-Pasha. That was an outstanding talk, and you all can see now why is it that CT and CMR truly has taken the front stage for evaluation of the aorta. However, ultrasound echocardiography still plays a role in several areas, which I'm going to point out. One of the important areas is that sometimes echocardiography is the very first imaging technique that points out to the observation that a particular patient has an ascending aortic aneurysm. So reviewing some of the imaging planes for the aorta by transthoracic, the parasternal long axis, of course, the most commonly known. But if you push the transducer up a little bit, in about 85% of patients, you can get a nice look of the ascending aorta, and that allows us to evaluate the size of the aorta. So that's an important view, and most of our sonographers now are truly working hard at getting it for us, and we should reward them by actually making a point about in the report as to the size of the ascending aorta. The suprasternal view gives us a distal view of the arch and the proximal descending aorta. And then a view that is not known that often is simply from a parasternal position, and in between view, between long axis and short axis, brings the descending aorta into a longitudinal plane. So that's a view that can be used, and I encourage more sonographers to try it and practice on it, because it is possible to see more of the descending aorta there. And then, of course, the subcostal view, as we see here. So here's a patient where we have all those views used. The aortic root appears normal. The ascending aorta has a fusiform aneurysm, but it's more than that. The descending aorta also has dilatation, and here is your abdominal. So using selected views, actually, it's possible to see a fair amount of the aorta, and sometimes echocardiography can be the very first thing that points out to the fact that a patient has a problem with the aorta that then can be imaged more thoroughly with either CT or CMR. TE gives us a much better view, of course, as we all know, and we start with the roughly about 189, between 90 to 100 degrees. You can see a very nice shot of the ascending aorta. You saw it on the previous talk very nicely. With about 120, you see the root very well with the aortic valve, and this is a view we all use to assess aortic root size and start looking at aortic insufficiency. And then you turn the probe to the other side, and of course, we see the descending aorta that now with the X-plane, we can see longitudinal and short axis view going all the way up to the arch. So here we have the distal portion of the arch, of the ascending aorta and arch. Here we have a fair amount of the ascending aorta that we can see, but there's a blind spot right about here where the trachea comes in, and that's where we can miss some disease if it's present there. Now, you heard very well the difference between echocardiography and CT-CMR for sizing. By ultrasound, the recommendations are still to go leading edge to leading edge. So it would be from about here down to the edge here. And when you do that, however, and compare to CT measurements, there is frequently, most of the time, very good agreement if it's done properly. Now, one of the important limitations of echocardiography is that for the most part, we are doing measurements of diameter in a longitudinal view, where, as you heard before, with CT and CMR, you can do the entire cross-sectional area, which provides a much comprehensive assessment of the size. Remember, our aortas grow as we go from children, adolescent, to young age and older age. Just with aging alone, the aorta size increases. But then also, for each age, it changes with sizing, with the size of the person. And therefore, a person that has a body surface area, let's say of 2.3, 2.4, could easily have an ascending aorta of 4.1, 4.2. So it's very important to continue to look at sizing when we are looking at the aorta. Here we have somebody with a 4.8 centimeters ascending aorta, which actually did agree with other previous numbers with CT, and therefore once in a while we could potentially use the echo as a frequent assessment and reduce the amount of radiation that we have to do with CT, although we still can do CMR2. Acute syndromes were extremely well discussed by Dr. Chamsi-Pasha. A couple of points to make. This is the classification, very well established and shown. It's a beautiful example of a type 1 that starts in the ascending aorta, but you can see also the intimal flap in the descending aorta. And this is a type 2, which ends in the arch and doesn't go beyond the distal arch. And this is a patient. Well, we'll move. Yeah, here we go. So this is a type B or type 3 starting in the proximal part of the descending aorta. Now, the important thing, if you have to do a TE acutely, and there may be some situations where the only option is to go quickly with the TE, those situations are less and less common, but they can happen. And if you're in that situation, remember the possibilities for having false positive and false negative. And the main cause of a false positive is a reverberation artifact. So here we have this image where you see this thing moving there. Is that an intimal flap dissection or an artifact? So a very nice study from Spain was done several years back, showing that artifacts move in parallel with the aortic wall. So if you're in doubt, here you have that one there, what is it? If you're in doubt, do an end mode. And you can see now that this so-called intimal flap is moving perfectly in concert with the rest of the wall. That's an artifact. Because an intimal flap will have its own random motion that will not be following the movement of the aorta. Here we have an example of that. Here you have what looks like a possible flap, but seen much better in the other views. Very nice and clearly seen here. And that is, of course, a type A, but type 2 because it ends in the arch. TEE can be very helpful for the assessment of the aortic insufficiency and the cause of the AI, because not uncommon is not a valvular cause, is prolapse of the intimal flap into the LV outflow, and that, of course, is fixed by the surgery of the aneurysm, and you don't have to touch the aortic valve. So in the presence of AI, actually TE can be sometimes quite helpful if you cannot assert whether it's valvular or is it just the prolapsing of the flap through the LV outflow. Another thing, we saw a nice case earlier from by CMR. This is a flap in the descending aorta. This could be a type 3 or type 1. However, in addition, there's this other thing. And the question is, of course, what is that? And hopefully it displays. Here we go. All right, well, this is a perforation of the fourth lumen. Here's the true lumen. This is all fourth lumen, perforation, and this is now a pseudoaneurysm. So this is basically a rupture of the dissection of the fourth lumen. Patients survive by creating a false aneurysm instead of bleeding to death. Those can be seen by CT, CMR, and of course by TEE, if you're fortunate enough to be involved in a case like that. You already saw beautiful cases of intramural hematomas and what they're caused by. This is the ultrasound imaging. This is the crescent-like appearance by both ultrasound as well as CT or CMR. And this is what by ultrasound you see with a penetrating ulcer. So what you have here, first of all, a lot of atherosclerosis. These patients usually have a lot of atherosclerosis. This is then a break point in a plaque, and then the actual penetration and pseudoaneurysm, because this is really is a rupture where instead of the patient dying, they create a pseudoaneurysm and contains the rupture. So this is the appearance by TEE, actually quite similar to what you saw by CT and CMR. And the important finding, take-home message, is these patients usually have a fair amount of atherosclerosis. And of course, you saw images similar to that, where you have the different classifications for penetrating ulcers and the importance of trying to assess the actual size of the pseudoaneurysm and the width of the opening and so on. And these conditions usually do require a surgical approach. This is one patient that we have the fortune to seeing. It was a young woman in a motor vehicle accident, and this is basically a rupture of the aorta. Again, survived by the grace of God because a pseudoaneurysm formed and allowed this patient to make it to the hospital and be treated. These obviously are extreme emergencies. And this is one area where really TEE still has a very good use, is the aortic atheromas, classifying the magnitude of the atheromas, describing the presence of ulcers in the plaques, the evidence of irregularities, and important, these fragments that are mobile, and we see quite often. Here we have a nice example of that, showing here. This is another one. This is a raised plaque. Here we have others. And they come in all kinds of size and appearances. Here, this looks like unidentified objects flying around. And there was a study that we did many years ago, Dr. Zogby with a fellow, and also with the collaboration of Stanley Crawford, who was an amazing surgeon for aorta. And what we did is patients that had this finding by TEE, and they were going for surgery for repair of the descending aortic aneurysms, we actually looked and found out what the heck these things were, and they were all thrombi. And that's why now aortic debris is clearly considered to be thrombotic material. And as Dr. Chamsi-Pasha indicated in his talk, there is not a great consensus on treatment. There's been only one trial that was used some years back. And the bottom line is that at this point in time, the recommendations are still to go with combination of statin and then aspirin and or clopidogrel. Treatment with actual anticoagulants have been not been that rewarding, and I'm not aware of any trials with any of the NOACs at this point in time. So this is obviously one of the findings that we look for when we are evaluating patients with strokes. These are usually more elderly type patients. And some of these aortic debris are quite interesting when you see them. As you saw some of these examples, they can be quite mobile and funny looking, but also quite dangerous. And if you have any one of these penetrating irregular big plaques with any aortic debris in the proximal descending aorta, but you don't have it in the arch, that still can go north. So when you're looking at older patients that you're doing TEs for strokes, any abnormal, irregular, large type of atheroma with any type of debris, if present in the descending upper part of the aorta, can be a source for embolization. Now, obviously, if you only see them way down into the lower portion of the descending aorta, then it's highly unlikely that they'll be able to travel all the way north. Those can, of course, cause peripheral embolizations towards the toes and extremities and so on. So a brief review of ultrasound. Obviously, importantly, some of the imaging views, some take-home messages is echocardiography is not uncommonly the very first tool that identifies a patient with an ascending aortic aneurysm. So it's important that we try to get the ascending aorta in every patient and, of course, measure it and report it. TEE becoming much less used for acute aorta syndromes, but there may be situations that you're called in because the patient might be too sick to be able to go through any other testing. And it's important to recognize, most importantly, the cause of false positive. Because overall, TEE is quite a sensitive technique for detection both of dissections as well as the penetrating ulcers and as well as the intramural hematomas. Aortic debris, I think, is one of the strong points of TEE because we can see them extremely well. we can assess the size and mobility of this debris, location, and their potential for stroke. With that, thank you very much, and we have a few minutes for questions if we have any from the audience here. So the question is, I'm assuming you're asking for transthoracic echo, right? Okay, yeah. When doing a suprasternal notch, how you can differentiate a dissection from innominate vein? Well, again, for you to have any concern with the patient having a dissection, you really need to see a linear structure that is flapping, and is flapping out of sequence with the movement of the aorta, okay? If you see something like that, then yeah, you need to be concerned. Now, obviously, that would be, since transthoracic, if you're doing it in a patient that is not having any symptoms, obviously, it would be something of concern that would make us request other type of imaging. But the key is to see that linear structure that is flapping, and that flapping motion is out of sequence with the normal movement of the aorta. Yeah. All right, well, thank you very much, guys.